started here in just a moment. I'd like to introduce our speaker for today. Kathy Szafran is the Executive Director of Mountain State Promise, Aetna, Better Health, West Virginia. She is the former President and CEO of Crittenton Services of West Virginia. Ms. Szafran has over 25 years of behavioral health experience encompassing senior level management, program, and policy development. She is a qualified expert witness for legal proceedings regarding the clinical treatment of abused children. Ms. Szafran has presented workshops at numerous national conferences, and she has presented at congressional briefings related to gender-responsive trauma-focused care for marginalized girls. In 2016, she presented at the White House specific to trauma-informed approaches in schools. She successfully integrated ARC, attachment, self-regulation, and competency trauma treatment framework into both residential and rural community-based behavioral health services. Ms. Szafran has nationally published research on the impact of trauma-informed care in early educational environments, universal pre-K through grade 1. Ms. Szafran is a recipient of the Commissioner's Award from the U.S. Department of Health and Human Resources, Committee on Child Sexual Abuse. She holds a master's degree from West Virginia University and is a licensed professional counselor with a certification in traumatic stress studies from the Trauma Center at the Justice Resource Center. It is my pleasure to introduce to you an amazing woman. She's got such important information to share with us today, so please help me virtually welcome Ms. Szafran as she takes over from here. Thanks, Kathy.
Hi, good morning, everyone. It's a pleasure to be here. I am going to start thanking Melody for a wonderful introduction. I appreciate that, and look forward to spending the next hour and 15 minutes with you talking about what we're doing at Aetna and kind of relating that to some of my life experiences as an administrator for a residential treatment program and community-based services, and also as a licensed professional counselor. So I'm going to go ahead now and share my screen. Are we on full screen?
We're on full screen, but we're on that other setting. So just make that adjustment.
Okay, let me fix that. Are we better now?
You're good to go.
Great. All right, so let's start again. Good morning. Just a little bit of information about where we are and how we've gotten to this place. Aetna, West Virginia was awarded the grant to do the foster care component for the West Virginia Medicaid system. So about 5 years ago, West Virginia rolled into 4 MCOs, West Virginia Medicaid. And at that time, they carved out the whole foster care population very specifically so that the foster care population would be set separate and continue in the regular straight Medicaid program. This past year, 2019, an RFP went out to now take the foster care network and place it within an MCO model for better care and coverage. And at that time, there were several applicants for the RFP, and Aetna was awarded it. And part of the beauty of this is looking at a whole new way that we're approaching caring for our foster care children in West Virginia. And I just wanted to make it really clear, this is an extreme cooperative relationship that we have right now with the West Virginia Department of Health and Human Resources, and we're really excited to be partnering with them. A common theme I want to talk about this morning and stress the importance of is that the foundations of lifelong health are built in childhood. Coming from the behavioral health world and coming to work for an MCO was a huge transition, but it really helped me understand how important it is to do this paradigm shift of wellness and well-being. And over the years, we have continuously learned more and more about the impact of childhood adversity on long-term health care, and the marriage between the child welfare system and a healthcare entity just really, really makes sense. So during our brief time together today, we're going to be talking a little bit about the history of West Virginia, but we're also going to talk about the science that we're putting behind our model at Aetna and how we anticipate that we'll be able to really change the flow of how we're directing our child welfare services. Then I'll spend a little bit of time talking about the Mountain Health Promise and then looking into the future. And when we talk about the bedrock science, you're going to get to meet an awesome woman who has been very instrumental in our work at Aetna, Liz Wendell, and she's going to talk to you a little bit about family findings and what that means on how we change our practice in caring for the children and the families who we have the opportunity and the blessing to get to work with. So I want to start with, so in front of you is what we have right now. So these are the statistics from West Virginia. So as you can see on the left-hand side, the arrow, the line on the graph has continued to go up. And that's the number of children we have in the foster care system in West Virginia. As of May's report, we have 7,233 children in foster care. And I have to say that the number has gone up slightly since this report. Per capita, West Virginia is #1 in child removal. We're also #1 in the use of congregate care nationally. As you can see, we have, and as you probably have experienced, we've really struggled with shifting services from our residential facilities into our communities. You'll hear all kinds of issues that we deal with, specific to workforce issues, looking at how do we get services in areas that are just difficult to reach, connectivity. We know that we deal with a population that is frequently extremely poor. We deal with, my dad would say poorer than poor, folks who don't have heat, running water, removing children because of these neglectful situations. And we really struggle with families living in poverty, specific to social determinants of health, and how do we meet them, and how do we help and support them. We also realize that we are probably in our 3rd generation of a substance abuse crisis, which is something that also West Virginia is just not very proud to have to be in the news over. Also, some of you may be aware that we have a Department of Justice agreement that is specific to our need to reduce the use of congregate care, to reduce the amount of children who are going out of state for care, and to reduce the use of intensive psychiatric medications for children who are really experiencing trauma. In addition to that, if you haven't noticed, we are dealing with an incredibly frightening pandemic, and it has greatly increased our social isolation of children and families, and brings us grave concern regarding the well-being for our kids. And the isolation of already isolated rural families, taking school out of the equation, children are dealing with food insecurities. We've lost the ability to have mandated reporters accessible within the school systems to view and see and be with our children. So it has increased our fears of what's happening with our most vulnerable population. Now, through the eyes of a behavioral health provider, which I was for a very long time, working in residential and doing clinical program development. And some of you may know that Crittenton is the only residential program in the state that's licensed to care for pregnant and parenting adolescents. And all of them are within the child welfare system. All of them have pretty extreme histories of abuse and neglect. And as a clinical person and working that program for years, I can honestly say that we probably tried everything we could to help our kids. Everything, of course, that's legal. And we tried things that are familiar to many residential programs. We tried point systems, we tried level systems, we utilized psychiatrists and medications, we utilized stages, just about anything to help these young women develop skills to be independent and self-sufficient, and to, as we would say, complete the program. And at times we were very successful, But there always were those few girls that no matter what we did, we all ended up with broken hearts. Sometimes their babies were removed from them because of their behaviors, or their behaviors had escalated to a point that charges were filed and the young women were put in detention. But what we were dealing with and what we were managing more frequently than not was behavior. And we weren't really focusing on what was the true root of the behavior, and most importantly, how can we help kids and families heal? For some of the young women we worked with, they spent the majority of their lives in foster care systems, perhaps adopted briefly, had disrupted adoptions. Wasn't unusual for our kids to have 10, 15 different placements in their short lives. We really knew that something big was missing, something very big. And we really were looking to see what that could be. We started learning more about the ACEs study. And I'm going to guess the majority of you have had some training on this, because that's one thing we're pretty strong with in West Virginia. We have an awesome West Virginia ACEs coalition, and we've really been spreading the word. But in case you're just maybe not familiar, in the late 1990s in San Diego, a physician by the name of Dr. Filidi joined a physician from the CDC, Dr. Andy, and they embedded 10 yes or no questions into Kaiser Permanente's social history. And they gathered a ton of information specific to childhood adversity between the ages of birth and 18. These findings consist of over 17,000 participants and was really, truly game-changing. And the more adverse childhood experiences that one has between the age of birth and 18, their data show that the greater the impact of lifelong health outcomes were. The worse your outcomes were, the higher your number was. So there was a direct correlation to what you experienced as a child and how your health is as an adult. They took the ACEs questions and broke them into three basic categories: abuse, family dysfunction, and neglect. The higher your rating came, 4 or more, you were 2 times more likely to smoke, 7 times more likely to become an alcoholic, 10 times more likely to inject drugs, and 12 times more likely to commit suicide. So here we're starting to learn in the late 1990s that there's a great correlation between toxic stress and the developing brain and the impact on the immune system. So it isn't just kids getting a bad shot at life, but their experiences are greatly impacting their biological setup for life. So we probably have heard about the alarm brain and the amygdala. And the amygdala is basically the part of the brain that really helps protect us and sets off the alarm to keep us safe. You may have heard it by the term of fight, flight, or freeze. Use examples of this is what happens if you put your hand on a hot burner. You don't have to think, I need to remove my hand, it's burning. You instinctually withdraw it. That alarm system in our brain keeps us alive. And for many of these young children who grow up experiencing this chronic stress experience, this part of their brain, the survival part of the brain, is the most utilized and becomes extremely strong, like a muscle that's just being overworked. So for many of these kids, they're coming into the foster care system and their ability to regulate emotions are very, very challenged. From a provider perspective, what do these kids look like when I would see them in their teens? And if we can follow that same pattern of fight, flight, or freeze, our fight kids, those are my girls who were extremely aggressive. They were our fighters. They were very, very easily irritated, difficulty with anger, trouble concentrating. We would take them and package them in these great little diagnoses. These were kids who we would say were attention deficit disorder We would call them oppositional defiant. We call them conduct disorder. These kids were in your face, very hard to regulate, very hard to calm. Then we would look at the kids who, we talked about fight. This is the flight. These are our very avoidant kids. They would stay in their rooms a lot of social isolation. These are the kids who would run away. They would run away to run. They didn't have really a place to go. They just knew they had to get away from. Everything was unsafe, no matter what we did to try to make the environment more safe. These are kids who we would quickly label as depressed, anxiety disorder. These were your real nervous kids. Really struggled with a million ways to keep them safe and to keep them from not putting themselves in a situation in a residential facility. Sometimes, especially if you're not a locked facility, we would even do things as take away their shoes so that they wouldn't run out the door, even knowing that at times, even in the winter, without shoes, they would just go. And our responsibility, of course, was always to stay with them and to keep them safe. And then for me, probably one of the more kids I worry about the most were the adolescents who we would call freeze. And this is really the constricted of emotional expression, we would see a lot of dissociative behavior, over compliance. Also with this population, with some of our girls, this is where we would get the cutting behaviors, the piercing behaviors. These are girls who had turned off so much of their emotional response to stay alive that they had difficulty feeling again and really, really struggled. And the sad part about all of this is for many of these girls who would come into care, and many who came to us pregnant and parenting, had been labeled promiscuous and over sexually inclined, and they would over aggressive, clingy, really inappropriately labeled things based on what they've learned on how to protect and care for themselves, and by their basic fight, flight, and freeze. So what does all this have to do with what we're doing at Aetna? Our practice at Aetna is really based on science. And really, we're looking now from the time of the ACEs study to date, a decade plus of research that's pushed us to change now how we view the children and families that we work with in the child welfare system, and a better understanding of the behaviors that we're seeing and what really needs to happen, and the importance of developing and creating that environment that helps these children heal and feel connected to people who care and love them. Like I said in the beginning, we know that the foundations of lifelong health are built in childhood. And we know that there's been a revolution over the last 10 plus years in biological science, neurobiology, and genomics, as seen with our understanding now of adverse childhood experiences and the effects of trauma on children and families. And this proves to us that right now we have a significant opportunity to rethink and improve the safety and the well-being of children and families. And for me, this has given me hope. As someone who's been in the field for quite some time, I am probably more hopeful now on how we can do our jobs better and reverse what has happened to these kids than ever in my career. And for me, it's a really, really exciting time. So right now we need to start talking about different things. We need to start talking about things like resiliency and how important healing is, and establishing connections and relationships for children, developing supportive ties within this child's network. Please understand, children that are unsafe in an environment and that are high risk for abuse need to be removed from that environment. But they don't need to be removed from those who care and love them. And we have a responsibility to help make that happen. Talking about the child welfare system that has been around for years and years, as a system that finds safety for children, which has been really good, right? However, we tend to be rescuing children too far downstream. We're rescuing children after the point of abuse and neglect have occurred. We need to try to figure out how to keep moving upstream so that we're keeping children intact before they fall in the river. And that's real important to our work. So the American Academy of Pediatrics has long recognized that the health of individual children is really the product of social, environmental, and genetic factors, and that adverse conditions can undermine the wellness of a child at any time. And the importance of brain development and the most basic brain functions help to keep us alive and to survive truly are those fight, flight, or freeze. But also at the same time, these can prevent children from being able to learn, to regulate and learn and to develop healthy relationships. We know that children that are in the foster care system are singularly disadvantaged and vulnerable population that they are, and are extremely high risk for persistent and chronic physical, emotional, and developmental conditions that multiply and accumulate as adverse experiences in their lives continue. Prior to foster care, the vast majority of the kids who we've all worked with are from families that are pretty devastated through substance abuse, mental health disorders, educational inequalities, unemployment, violence, struggling with parenting skills and involvement in the criminal justice system. We understand very much now that this is multi-generational. And so when we're focusing on helping heal a child, we also need to focus on how do we help and heal the family. A recent study from the University College of London tracked more than 350,000 people who were using, by looking at their government data between the years of 1971 and 2019, and they found that throughout this 42-year span, adults who spent time as children in foster care were 70% more likely to die prematurely than those who did not. So this actually aligns beautifully with the ACEs study that shows that there is a 20% reduction in years for children who have multiple adversities in childhood. But the most important part of all this is that we can develop resilience building and services that help support, build resiliency, and help heal so that we can mitigate some of the impacts and the effects of adverse childhood experiences. So, science to practice. I have the great pleasure to introduce Liz Wendell. Liz is an expert in family findings and youth connectedness. She has been extremely instrumental in the implementation of Mountain Health Promise. She's a partner with Kevin Campbell, and he is an incredible youth permanency expert and founder of the Center for Family Finding and Youth Connectedness. And I wanted so much, Liz, to be a part of this because this is the boot on the ground, the work that we're doing in West Virginia right now that I certainly want to share with you. So please join me in meeting Liz and listening to the work that she's doing in helping us change in West Virginia.
Thank you, Kathy. I appreciate the lovely introduction, and I'm really excited to chat with you all this morning. And I want to start by just framing a little bit what we're talking about in terms of family practice work. I think it's really challenging when you work and live in child welfare systems day to day to sometimes connect all of the moving parts of what's going on, all of the silos, all of the fragmented pieces of this, right? We're working in judicial systems and child welfare systems and thinking about ACEs studies and family finding practice, social determinants of health, and there's all these modalities or models or language pieces or systems all the time. And one of the things that Aetna has really committed to and really aligns with family finding practice worldwide, which Kevin and I both support, is thinking about family work or family practice, no matter what your role is, whether you're an administrator or you work directly with families, from a humanistic, whole person, sort of anthropological place. You don't have to have every bit of language around a particular practice. You don't have to know every statistic. You simply have to accept some basic scientific truths around what we know from the data and from the research and now from the practice about what actually sends young people towards successful, healthy adult lives. And we know that that's so I was actually chatting with some of the folks who organized this before our conversation today, and hearing a little bit more about the Connections Matter training that is so wonderful in your state. And I think that really is what I'd like to get to this morning in my little piece here is, you know, we have often been placed in this box in child welfare of thinking about needs and services. So what's wrong with this kid? What's wrong with this family? What do they need? What services can we provide? Of course, families often do need services. Kids often do need services, but we can't simply focus on that piece, right? We have to think about that whole person, whole family perspective. And we know the single most important factor for young people as they grow up and transition into adulthood and are successful or not is their relationships. The study that is sort of built around the family finding model is that one person, just one, in a kid's life who is a consistent, unconditional, lifelong support, not placement, you'll notice, just a support, can make the difference between that child's mental, behavioral, and physical health outcomes in adulthood versus a kid who does not have that. So when we were building this for Aetna, we thought about some basic concepts, and you'll see them on your screen here. And so I just want to talk through them briefly. And one of these that really kind of connects to what I'm talking about in terms of creating space for connections is what's predictable is preventable. So Kathy spoke beautifully about what goes on for our young people now. You all have those stories for yourselves, I'm sure, in terms of your own practice. We know system, especially kids who stay in the system a long time, don't have connections, end up having service after service after service, are much more likely to have all kinds of negative outcomes in adulthood. In fact, the foster care system in our country, in the United States, has the worst health outcomes of any population in our country. So kids in foster care are twice as likely to develop heart disease, diabetes, other major health conditions, and sort of the health arena. But I wanted to speak to that briefly because I think it really helps us think about, okay, why would a managed care organization dive into this world that is child welfare? So when we're talking about what's predictable is preventable, we now have enough information about what goes on for our young people to predict it and then look back and say, what should we be doing differently? And I'll add to that, to my initial point, what are we stop doing or start doing, right? It's not just about adding models or services or practices. Sometimes it's about stopping certain practice. And I think I've started to, and I'm going to share a story in a little bit here, watch in West Virginia something really interesting happen around stopping practice, which is the gut reaction of lots of child welfare folks, not just in West Virginia, although that's been my sort of main focus the last couple of months, is placement. Placement, placement, placement. Let's get this kid safe, which is important, right? We want our kids to be safe. But because of the overwhelm of the system, it becomes placement, and then I'm going to move on to my next kid. And that is a practice that has to stop. And so we've really done some work in these large cross-system, defragmented, non-siloed teams, Aetna care managers, state workers, ad litems, judges, placement folks from residential facilities or shelters, CASA advocates, all kinds of wonderful people who are coming to the same table. So that's the defragmentation piece, and saying, okay, how are we doing this work? And what's next? What next? Until we're to the final frontier, which is, does this child have a network of healing around them? And I'm going to get into that a bit in my next slide. I want to give that context and framework. So obviously for a managed care organization, but also for the state in general, it's really important to think about how we're building these practices, what we're taking away from these practices, no matter what you're trying to impact. So obviously Aetna's trying to impact health outcomes, right? If you look at the research in child welfare today, there's lots of research that says child welfare will become a public health crisis. And I would argue already has, because so what's predictable is preventable. The second of these is our biography, is our biology. So Kathy alluded to this a bit at the beginning. We have so much wonderful information now about what's happening for our young people. And one of the things that I really enjoy about this work is how much we've been able to untangle around not only, okay, this kid has trauma, but also what does their ACE score mean for their cellular biology or their brain architecture. And so the language we use most often that seems to help people with this particular concept is most of our young people, the behaviors they have, the diagnoses they have, how they enact certain things or respond to certain things, or the language they use to communicate, is all part of them being a Formula One race car, uniquely built to survive the life they are currently living. So instead of this child is manipulative or has all these behaviors, the reframe is their biography, what's happened to them, what they experience, is their biology, their body, their system, their super system, all of the pieces of that have been uniquely built for them to survive the life they're living. So then the question becomes, what do you do with that? Well, we know, very similar to a teeter-totter, right? You can have lots of adverse experiences, but there's now also lots of studies about PCEs, which are positive childhood experiences. If we can begin to balance that for our young people, that's huge, right? You can change the architecture of a child and an adult, by the way, in case anyone's interested in adult work, cells or brain architecture long into their 20s, 30s, 40s, 50s, and 60s, we now know. For those of you who study brain science at all, for a long time there, it was you're kind of locked in at age 27. That's not true at all. And so we have an opportunity in our system to think about, okay, how do we dose our kids with positive experience that can counteract some of the trauma that they've experienced or the loss of relationship? Most of those opportunities for dosing happen in network. And that network is those people who love, support, provide positive feedback or interaction or fun or physical activity or fill in the blank for what kids in your life need to be happy day to day. That's where the healing happens. And that's where the biography is your biology changes over time. And we all, as child welfare professionals, can influence that by creating those mechanisms, supports, relationships for those positive childhood experiences. Then, of course, the last concept, which is my favorite, because it's a hopeful one, is the brain and the body want to heal. So this concept, like all the others, is based in lots of bedrock science around this, but I will keep it simple for the purposes of today. One of the things we see very quickly when you do family engagement practice, network building, family meeting, collaborative family engagement, or any derivative of signs of safety is what's used most common in Western Europe, very similar. Collaborative family work is used in most of Australia at this point, very similar practice methodology, no matter what you want to call it. One of the things we see is the moment you offer space for some hope building, some no decision about me without me for your person or their family, some network building around them, some opportunities for dosing of relationship with someone who's not paid to be in their life. you will see some pivot. Now, I'm not going to say that every kid, the moment they meet their auntie for the first time, is miraculously cured. It doesn't work like that. But we know through studying all different kinds of kids in all different kinds of situations in child welfare that every brain and body has the capacity to do that healing work. The earlier, the better, right? Kids' brains are more plastic the younger they are. By plastic, I mean moldable, not the physical plastic. But you can do it all the way through. So no matter what, I'm guarantee some of you are thinking about a particular kid right now. Oh, what about this kid? Yes, you can do it with that kid. In fact, I started my career working with only older youth, so 19 to 21-year-olds who had spent their entire lives in the child welfare system in the state of Pennsylvania. Some would refer to that group as the roughest group of kids ever, but I adored them because they were absolutely brilliant and they knew what they needed, and their brains and their body had this desire to heal. And often the simplest way to do that was to ask, what do you have a lot of? What do you need? And how do we build that around you, with you? So the analogy we use in family finding quite often is your young person walking behind you, beside you, or in front of you? And the way to think about that is, are you making decisions for them, without them, with them, if that's appropriate and healthy for them? Or are they leading you through it because they're in a space of capability to really define that for themselves? So that's sort of an illustration of that last concept. So if any of you have ever had the opportunity to listen to Kevin speak, he is perhaps one of the best child protection experts and advocates in this entire universe. And he says this probably not every day, Kathy, but I would venture to say most days. I sometimes hear this in my sleep after working with Kevin for almost 15 years. But I'm going to read it aloud for you twice just to let you all absorb it. So safety is temporary without healing. And healing happens in networks of natural support. So I'm just going to say it one more time so we can absorb this. Safety is temporary without healing. Healing happens in networks of natural support. So I'm going to untangle this a bit for us because I know it will be helpful for folks. So I want you to think about all of the young people that you've either worked with, heard of, are related to. Knows at least one young person on this call, I'm guessing. And I want you to think about a particular young person that you've got in your head where you found the best placement or a safe placement or even a family member perhaps, and you put that kid there or somebody else did and you're working on it and it's going great, right? There's always a honeymoon phase, especially with older kids. Everything's perfect. You've got your safety. And then everything falls apart. So if we're in the room together, I'd ask you all to raise your hand if you've had this experience, but I know most of you have, and I know Kathy has. The reason that is temporary is not because that kid or that caregiver or that placement doesn't want it to succeed. It's not even because that psychiatric hospital or shelter doesn't have great staff. I, in fact, have worked with most of the shelters in West Virginia at this point and know they have wonderful staff. It's because the work that needs to be that particular type of dosing is actually part of and connected to a person's biological response system. There's something that and I won't get into all the nerdy stuff today, although if you're interested, come find me and I'll be happy to talk with you about it. There's lots of things that happen in your protein systems, your cellular systems, your hormone systems, when you are having connections and positive experiences, whether that's going for a walk with mom or laughing on the phone with your sister, or even crying to someone who says, hey, I got you. I'm here for you. It's going to be okay. There's all kinds of things that are happening in your brain and your body all the time when you have those experiences. So the reason that safety is temporary without this healing component is the kid does not ever get that feedback loop, which is an essential part of who we are. And so over time, just to all together, if you repeatedly don't have that, your body begins to create mechanisms around meeting it in other ways, which is how we end up with foster kids in adulthood who are more likely to have heart disease, diabetes, engage in other behaviors that contribute very significantly to their physical, mental, or emotional health. But the best example of this, and most of you will know this one, is if you study babies, particularly babies in Europe in the 90s or so. If you look at this research, those kids cried when they needed something, right? Most babies do that. When you really start to worry is when those babies stopped crying. So in Eastern Europe, for those of you not familiar, one of the things that happened was there wasn't enough human capital to meet the needs of all of the kids in those orphanages. And so those babies stopped crying. Within months of learning that behavior, their entire changed in terms of how their needs got met and how they regulated themselves. And so this is just one of hundreds of thousands of examples in sort of a foster care or congregate care setting that really speaks to this safety is temporary without healing. So the healing happens in networks of natural support. And that's really the family finding piece of this that I want to dig into for the last couple of minutes here. So networks of natural support are people who love you, might love you, could learn to love you. And those are the three questions that we ask when we do family finding practice and coaching in West Virginia. So for those of you not familiar, Aetna is beginning to pave the way in doing child welfare work differently, not just about health outcomes, but about really meeting that whole person, whole family need with their counterparts in various systems. We're going to have to do this together is the simplistic version of that. So that network happens with those relationships. And I want to encourage all of you not to think of family as traditional family, right? We all have families. In fact, the average American has 200 first, second, and third degree relatives. You don't necessarily like them all. That's okay. Kids are the same. If you've ever been somebody who said, this kid has nobody or has no family, or you've heard someone say that, that's okay, but don't ever say it again because it's not true. Everybody has people. Now, I'm not saying all 200 of those people are going to be safe, appropriate adults for this kid. But I guarantee you some of those 200 are. And so that's really the family finding work, is that searching and engagement and building of network around a young person to begin to dose them. And again, it's not just placement, right? We've worked with all different kinds of young people in West Virginia. And some of my favorite stories thus far are not kids who went to live with somebody, but had a really successful experience because they had the opportunity to develop a relationship with somebody or multiple people. So I'm going to read this Dr. Bruce Perry quote. For those of you not familiar, Dr. Perry is one of the, I just saw this chat, so hopefully this will help with my audio. Dr. Perry is a very famous neurobiologist and psychiatrist and brilliant man who does all kinds of work on restorative justice for kids in child systems. So the more healthy relationships a child has, the more likely he will be to recover from trauma and thrive. Relationships are agents of change, and the most powerful therapy is human love. So this is one of my favorite quotes from Bruce, but he has prolific amounts of information online, as well as has written many books. So if you're not familiar, I encourage you to read some of his, particularly Boy Who Was Raised as a Dog, which is a very wonderful book of vignettes of stories that will really help you kind of apply the science in a way that's palatable to most humans who maybe don't like science so much. But he's kind of brilliant. So as I mentioned briefly, we've been doing this work in West Virginia. We're now doing it in Kansas and Kentucky. Kevin and I do this work all over. We've just started some work in England. Kevin's done work in Canada, Australia, and everywhere. But the practice is always the same, which is how do we build these networks? What does that healing look like? And it's different for every young person. But I want to just share to close out a particular story for West Virginia that I actually just got an update on this morning. Wasn't going to share this, but I'm so happy about it today. I'm just going to tell everybody I talk to. So this is a case we coached, very standard, since been in care a while, has some gender identity stuff going on, but is only 10 years old. And that's really why their placement disrupted. And so this person's been in care, has some really challenging behavioral issues, but is also, or was, I should say, actively suicidal because of all of the relational loss and some other things that had happened to this child. And so when we started coaching, we heard all of the standard things. This kid needs inpatient treatment for years to overcome all of this trauma. This kid has no family. You name it, we heard it. And I share this story for two reasons. One, something pretty miraculous happened, which is that in gathering this professional group, the guardian ad litem, the person from DHHR who represented them and her supervisor, the Aetna care manager, shelter case manager, and a couple of other folks who were really engaged with this kid, we quickly realized that everybody was worried about the same thing, but had never had an opportunity to come together in the same room and talk about it. And I shouldn't say same room, it was a phone call, of course, because of the pandemic. But it was really amazing to watch what happened when those people came together around three questions. Who loves this kid? Who might love this kid? And who could learn this kid? And what quickly happened is that team mobilized around, we're going to build a network, and we're going to have to be mindful about the dosing of that, right? If we bring 20 new people into this kid's life tomorrow, that's not going to work. But let's think about how to slowly do this over time and what that might look like. And as a concept, let's ask this young person what's most important to them and what they have a lot of and what they'd like to see. So fast forward a couple of weeks, we find out that this child is scheduled to go to an an out-of-state facility in Florida for treatment. Obviously, the team is very worried about that and comes together and mobilizes to have a conversation with the decision makers and say, hey, we'd really like to push pause on that because we think we can build this network. So that was success number one, right? These folks came together and changed that outcome, which would have been really rough for that kid. As of this morning, that young person is scheduled to enter into a kinship arrangement with a grandmother who has a network of support around her as well, which this team has built, including spending lots of time in family network meetings with her to think about what they're going to need, right? This kid's not going to be magically better, but how do we navigate what they need as they grow and learn and change and have behaviors and all of these things? What does grandma need? How do we build that? The amazing state social worker working on this sent an email to our team this morning saying, I had a Zoom call with this kid last week, and I have never seen her happy until today. And so, it was just a simple email, but it really, they still get me right here. It was really, really amazing to read somebody who really knows this kid and really is invested in this kid say that. Talk about, she goes on to talk about what's gone on between this young person and their grandmother and building this network. And at the bottom, she wrote something that was really important to me and is kind of at the core of family finding work, which is, here's what I'm doing next. This isn't done. Things are still going to happen. So here's what I'm doing next to continue to network build. So I just wanted to share that as sort of a highlight of, the much bigger group of work done by Aetna and all of their wonderful folks in the managed care organization, and really trying to change the trajectory of how we practice child welfare and how we think about families differently and how we focus on capabilities within families instead of just needs and services within our systems. And I think, this particular young person's story is a great example of that. So I'm going to stop there, and thank you so much, Kathy, for letting me join and share. And it's been a pleasure.
quickly share what you've already kind of done with BCF and some of the shelters?
Sure. Yes. So Kevin Campbell and myself have been teaching this model for 10 years. And so we have done very intensive training of family finding practice, which is great. Trainings are important, but as you all know, you can go to a great training and then you have to go back to life and practice as usual. So one of the things we've committed to is coaching beyond those training sessions every week for multiple weeks for every group. So we did it for all of the BCF staff, which is the Bureau for Children and Families under DHHR. And we've also done it for all of the Children's Home Society shelters and are now starting on other shelters in the state. So we've got probably 40 hours of training and coaching to go. But what's cool about coaching is it's not just talking like this about relationships, which is great. It's really, really targeted. You're going to bring a young person to the table and we're going to work it through with you. You're going to have access to these 2 experts in family finding practice for the next 6 weeks. And we're going to walk through every step of the way. And what really matters is not what you're doing in the coaching, not what you're doing in the training. It's what happens between. So you get a week between to do your practice, to practice your practice, we call it. But then you back and talk about what you've done and what went well and what didn't and what questions you have. And it's experiential learning, which is really, really how this changes. It's how systems change. So Kevin and I have been doing that work in West Virginia for many, many months now and are continuing to do that with various groups of shelter staff. We will hopefully start on residential staff in the very near future. The goal is to get this sort of anthropological, not just this one practice, but how do you think about this to as many people as possible so that we can really begin to transform our child welfare systems and the other systems that impact that.
I just want to thank you, Liz. You can see, guys, why
Thank
we're
you.
so excited to have Liz part of this presentation and the work that we're doing. And it really is a game changer, and it's changing how we see and work with these kids. So we're doing much more than discharge planning. We're doing life course changing, and that's so important. So I know Liz has to get off to get to another meeting, and she's going to be with us in West Virginia, hopefully for a while and a long while. We're sharing her now with other states, unfortunately, but we're building sustainability within West Virginia with our staff and with some of the shelter staff right now so that we can continue moving this model forward. Like I said, it's a practice. It isn't an event. It's not a training. It's how we implement and make change within the system. So thank you so much, Liz. And I can't be more happy to have you as part of our team. So
Thank you, Kathy.
Thanks. All right. So we're going to go ahead and go on. So now you're probably wondering, goodness gracious, what all does this have to do with a managed care organization now working within the foster care system in West Virginia? And as you can see that we're talking about really changing practice in how we work and we address with kids. And the model that we've put together, you'll see, helps us really kind of focus on how to get there. So the entire program, Mountain Health Promise, it supports the Family First federal legislation, which I think some of you may be aware of, that for the first time allows us to use $40 to do preventative work and to really help support our practice regarding early intervention and family reunification. And this is a paradigm shift using person-first, family-centered practice, and moving from rescuing children to supporting families, and moving from child welfare to family care. That I think is a really important way for us to start talking and start changing our language. And for one thing, I have to say this, I've been in West Virginia, lived here for 30 years. I love West Virginia. I can't speak enough about the good that we have going right now within our state. And acknowledge that incredible pots of brilliance, I call them, as far as individuals and organizations and communities providing incredible care and services. But one of our problems, like with most states, is how fragmented it is. And how do we bring it together and share and build in support? We talk about Gestalt, right? And all the parts, You know, the whole thing is greater than the sum of the parts. How do we bring this together into work? So first of all, you know, make sure that we're also always person-centered. We will be trauma-informed. One of the amazing things that drew me to Aetna was that they are a trauma-informed corporation, which is pretty outstanding. Ongoing training, very consistent. How do we become culturally sensitive and stay culturally sensitive? One of the things that I was impressed with Aetna is coming to the state with West Virginia people who know the state. We're not here to do to West Virginia. We want to be here to do with and in support of West Virginia. And I think that is really, really important about the work that we're doing. So who are the members? Who are going to be the members of this Mountain Health Promise? So we just started on March the 1st as we rolled out the program. And ironically, on March the 11th, we went into COVID isolation, right? But our members are the children who are currently within the child welfare foster care system, children who have been adopted through the foster system from West Virginia, children who are receiving socially necessary services, which are supportive services to help families reunify or to stay together. And then something new that you'll be hearing a lot more of is children who are involved in the seriously emotionally disabled waiver program, which is a new program through Medicaid that is allowing us to offer intensive clinical services to children who are the most at risk, children who can hopefully get them from residential programs back into the community, with families, or to prevent them from going into residential care. So it is an awesome program that you will probably be learning more about. And if you have any providers out there who want to learn more about it, just let me know. So the next question is, what is Mountain Health Promise? Why is that different than in Medicaid? Because I think for myself initially, I thought, okay, so this MCO is going to come in and is going to take over healthcare, right? Like our own, we have MCOs and our private insurance. But the whole approach that I'll be talking about truly is a total approach for the youth and the family. So, and it includes an individualized care plan and services that help support and guide the members. And in addition, there's value adds that help support from laptops and tablets for youth to legal aid services. So I will touch on that. Where with a traditional Medicaid service, you receive the services, but you don't have that tie-in and that coordination, nor do you have the ability to have individuals like a system of care, which I'll talk about, help support and navigate you through, excuse me, and through families through this really complex system that we work. So our whole approach at Aetna really is in partnership with children and families, and a real partnership with specifically in the Bureau for Children and Families, wanting to go into be able to look at early identification, like I said, moving upstream and working more preventatively with kids, going to higher levels of care and helping families work to be able to get their children back. Services that are inclusive to the family and person first, for like wraparound services, and looking at intense efforts in keeping families and family networks together, or finding additional family networks for children. So there may be a time where a child cannot ever go back to a particular person, a parent, but that doesn't mean that we can't find supportive family members to help them. And working with those networks, one of the beautiful things about the West Virginia foster care system is the majority of kids right now are in family care, in family care foster homes. And that's something that is very important, that helps keeps kids connected, and really looking at how do we work is addressing the whole family needs. Our care managers are like the backbone, truly the spine of everything that we're doing. Our care managers are registered nurses, licensed social workers, licensed counselors, some non-licensed folks that serve as primary points of contact to each and every member. So every child within the foster care system or adopted from it will have a care manager. Their job is to do a thorough assessment that also includes adverse childhood experiences, social determinants of health, really intensive way of working with that family member and the caregiver involved, and working on planning and facilitating and developing a care plan, coordinating that, working with the department on it, working with them and their family members and caregivers with it, and really advocating for the services that the children and families need. Peer support specialists are also an important part and are available to help and support and guide our members. Within our care management, we really strive hard to have a seamless service delivery. I'm going to talk about 3 different levels of care management that we're offering to our members, that we really are aligning with what our member needs and the goals that are set up for them, not the goals of how we think it should be. We really try to keep things focused on what the member and the family members are particularly in need of. Looking at the biosocial needs, one of the beautiful things about our care managers, they're in West Virginia. They are West Virginians, and I'll show you a map of where they're located throughout the state. So that's a very unique feature that makes it very important that they do know what's happening in their communities. They know the services that are available and how to help tie them together, and including the social determinants of health. Does this family need their electric turned on? Do they need heat? Do they have beds? How do we get back to the basic things that help support families instead of pulling families apart? So as I spoke, we have set up our care management system in 3 levels. Tier 3 is the most intensive level. Those will find our almost 500 to 700 children who are in residential care in and out of West Virginia will all have an intensive care manager. And that is a ratio for care management of 1 to 17. So they do have an opportunity to, on a weekly basis, work and talk to the member and the member's placement. Our goal, of course, was that they would be able to visit the members, and with COVID, we've not been able to do that yet, but hopefully we want to be able to develop that type of relationship. And in addition, in the state of West Virginia, we've also assigned a specific case manager to each residential program so that the residential facilities also have that connection directly with a person from Aetna who is working with the members that they have within their facilities. We have supportive care management, which is level 2, which is a 1 to 36 ratio. That is maybe children who are just in a nice, wonderful supportive foster home or a grandparent kinship type home or even a fictive home. In addition, we have population health, which is a 1 to 75 ratio, which is probably more like our adoptive families. It's interesting, I think I was amazed by the amount of children who've been adopted through our child welfare system. And if we have over 7,000 right now who are in foster care, we have about another 13,000 that we have enrolled in that are part of the adoptive system in West Virginia. So this is the map of West Virginia, of course, and this is how our care managers are located throughout the state regionally. If you want additional information, please send me an email and I can tell you exactly who the supervisors are for each region. And if you were interested in a particular member who you're involved with, we could help connect you to that care manager. But you can see that we've covered the entire state with folks from West Virginia helping folks from West Virginia. So how does this kind of look in practice? I'm kind of keeping an eye on the time because I want to get through this and have some opportunity for questions. So how does it look in practice? And you can see that how we're working with DHHR and Aetna. We do have shared responsibilities. We will help with it and participate if the department likes with the MDTs. Doing the regular case contacts, coordinate with any legal teams, CASA members, guardian ad litems, coordinate with RAP facilitators, and really working on improved outcomes. And then you can see on the far sides, on the left and the right, what are DHHR workers' responsibilities? You know, they're still going to be doing all the investigation of the abuse and neglect. They're still responsible for custody and placement. They will still refer to socially necessary services or to the CSED waiver program. They will still coordinate the whole reunification. On the other side, you'll see Aetna, and our job is to provide the feedback to help develop the care plan, help you work through socially necessary services or the SED waiver, and really kind of help tie together. Very much a very cooperative relationship. So since March 1st, which we are like finishing our 5th month, we have enrolled really now over 20,000 members. And you can see, I won't read it to you, how many care plans we've completed, welcome letters. We did all of this within the first 90 days, which was really exceptional, understanding that we all had to return home to work. So I was crazy impressed with our care management staff and the ability to put out this large amount of work in a very fast time. One very unique thing I want to talk about. So we know in West Virginia, we have a West Virginia system of care that is a program that operates through the Department of Behavioral Health and helps really look at kids going out of state. Aetna has embedded within its program, we have our own system of care that are really uniquely specialized clinical managers. We have 4 of them. Whose primary responsibility is to reduce barriers, improve access, and really to look at how to maneuver and work within the systems. We felt this was really important to defragment and bring the systems together. And I'll go through this quite quickly, and maybe the PowerPoint you could review at another time in detail. The one system of court is juvenile justice. Courts court order kids into care. How do we better work with them, support them? How do we give the judges enough information and make sure that they have what they need? So we are working with the Bureau of Juvenile Services. We're working with the Court Improvement Program. Actively involved, our individual here, his name is Tyler Kennedy, and he is our liaison with the juvenile system of justice. And it's just a great way to start pulling and connecting the pieces. Of course, recovery and resilience. This is another important role we have. Jamie Cantley is our person here who really helps. We have a recovery peer support person on staff. How do we incorporate and help family members heal through recovery and build resiliency? And her whole responsibility is to help maneuver and work through it and build the services that we need. We know that we do have more and more kids coming to the table with addiction issues, and how do we consistently help build and support that they get the help that they need? Childcare. The childcare system is no easy system. So understanding someone who knows how to work through it, to help us with advisory groups, to help us hear what our members are saying, what the families are saying, what our providers are saying, is critically important. And this is Teresa Kelly. She's done a great job, and is just right now totally psyched about family finding and has been working and learning coaching. So we're really excited about how this continues to roll out. And the last of this would be the adult system of care administrator role, which is to really help for those, with so many kids who are transitioning into young adulthood, and how do we create a way that they leave the child welfare system with support and connection. I don't know, as a parent myself, I know that my son wasn't independent and self-sufficient at 18 and needed a lot of love and support to maneuver and work through early young adulthood. And we need to make sure that our folks and our children have that also. So putting this all together really is a coordinated effort. So we talked about the importance of the care coordination team. We talked about interdisciplinary care team. The training collaborative is, we're just starting to roll on that, and I'm very excited about it, because we are looking at how do we take the pockets of brilliance that we have in West Virginia, our true talent as trainers and educators and child welfare experts, and tie them together to make them stronger. And then where do we find areas that we're weak and we need to grow and develop? And we'll be putting together a statewide initiative, and our goal is to do that very cooperatively with the West Virginia ACEs Coalition. And Aetna has a 10-module training program that we want to vet in West Virginia, and to have it work to meet the needs and to keep rolling this out, because we know that the more we know and the more we understand, the more of a positive difference we can make as we look at children who have experienced a lot of adversities, and how we really have to work on building resiliency and helping them heal. And then the governance and the member advocacy, and that's something I spend a lot of time with. We have a governance council. Some of you may have been aware of that or part of it. That's really working with the stakeholders. But my most important group that I'm working with right now is my member advisory council. And that's my member group. Those are parents whose kids are in foster care. Those are foster parents. Those are adoptive parents. Those are grandparents, relatives that care for kids. And we're meeting with them as often as we can, hopefully monthly. We're doing a lot of it virtually, which is a little more challenging, but we're listening. And we need to hear, because they will be the ones who are going to direct us and help us. And then we need to send that up to our governance council. So those folks who can help actually work the system policy-wise and what we need to implement to make this change significant will come from that group. So I'm going to wrap this up. The possibilities here are endless. We're 5 months in. Can't wait to see where we're at next year. And the networking that we can start building, looking at the numbers and reducing the youth in care, developing a strong continuum of care, and really kind of looking at resource integration. This is a great quote from Steve Tuck. Steve has been working with us, if any of you know him, with the emergency shelters. He was the first one. He probably was my biggest not fan of MCO, and now really kind of understanding and enjoying and working with family findings and the family connections, teaching and coaching, and the wonderful things we're hearing from his shelter managers and care managers about the work and helping kids who come into shelter with nowhere to go, finding folks who love them, who could love them, and who can learn to love them is so, so important. So with that, I will unshare my screen, I hope, and we can I hope I'm doing.
Don't even worry about it if you leave it like that. I've got some ready for you, okay, Kathy?
Okay.
Let's see the first one. I am wondering about the connection between folks doing this marvelous work and the public school system. Teachers can be parts of the caring network, but there seems to be a lot of siloing between these areas of activity.
Yes, 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 and yes. The schools are extremely critical, and there have been a lot of efforts into getting services into schools. We're totally aware of that. It is definitely part of our plan. We have, as part of our stakeholders, we have folks from the West Virginia Department of Education, and we are listening. And I was one of the founders of the Trauma Informed Elementary School project. So I totally think that the earlier we see these kids in the classrooms, remember I said, let's move this upstream, that we can get folks involved with helping and supporting families instead of pulling them apart, helping the schools coordinate and work intensely with the families is another really central to how we can make things better for kids. So yes, how's that?
That's great. There is wonderful work happening with expanded school-based mental health in the schools. So
and
wonderful.
Handle with Care too. I have to give a shout out
Absolutely.
to Handle with Care and the incredible work they do. I think there's a lot of work to do, but I think we're certainly moving in the right direction.
Okay, here comes another one.
Okay.
How are you connecting with primary care facilities, FQHCs across the state, again, moving upstream? How might primary care incorporate all this before the children go into care?
Absolutely, extremely important. We're working with the Primary Care Association. We have had pilot projects with the federally funded health centers, and you will be hearing more and more about our work with them. I think, especially with the training and the opportunities to start doing this kind of work and referring to us for help, we're going to be there for them.
All right, here comes another one. As behavioral health provider, wondering how kids who are not in care, i.e. living with at least one biological parent, but are heavily affected by ACEs, can be involved in the Mountain Promise program, thus moving upstream.
Well, unfortunately, right now, our membership is purely those who, are in the custody of the department. And our hope is that through trainings that are open not only to providers who work with kids in foster care, our trainings and all of our workshops, and integrating the services and trainings throughout the state will offer opportunities for community providers who work with children who have not yet come into the system. And it is really the goal to prevent kids from coming into the system. So those opportunities will be there for them to learn, and hopefully will help to support them down the road as the program continues to grow. Family First too, I'm very hopeful, will allow some additional services for those high risk but not adjudicated kids that we work with.
Okay. I do have somebody who was asking, and I'm not going to ask you to do it at this moment. They wanted to have you show one of your slides, but you did indicate that you would be willing to share your slides with the audience. So
Absolutely.
if we will send that all out, as I've mentioned before, with your resources and your follow-up emails. And then I'm going to assume that Ms. Szafran would be happy to answer your question. We can give you her email address and you can ask her something specific. Does anybody have any other questions in the Q&A box for Ms. Szafran before I let her go? Just checking to see.
Thank you all, and feel free. It's szafrank@aetna.com. Happy to talk to you. Let me know how we can help.